So hello friends, how are you? So this is Dr. Chandni for NEET-PG 2024 Recall Session Pediatrics from ADrPlexus. So hope you have done your NEET-PG exams well. So now we are here to discuss the recall questions from Pediatrics. So far what I've got the review of the morning session and evening section. The most commonly asked topics from development, immunization and all were quite low on this NEET-PG. So we had a lot of repeat and questions from repeat topics as well, and few questions which was quietly twisted. The options were quite twisted. So let's move on and see how the first session was now. Okay. So we'll first discuss the first session questions. Okay. So a child with thalassemia who was on bone marrow transplant presents with aplastic crisis. Okay. So they gave aplastic crisis. Which among the following organism is the causative organism? So options were histoplasmosis, parvovirus and all. So as we see here, aplastic crisis, we all know the answer is going to be, yes, it is parvovirus. So aplastic crisis is seen in parvovirus. Multiple times we have studied this. This is also from our VSV. So erythema infectiosum caused by parvovirus. The other things which is caused by parvovirus is non-immune hydrops fetalis in case of fetus, aplastic crisis in case of bone marrow transplantation or in sickle cell anemia patients, pure red cell aplasia, and myocarditis. These are the other features of parvovirus B19, and this parvovirus B19 was also a repeat topic from INI-CET 24. Okay, so the answer is parvovirus. Second question. A 6 weeks old neonate, so the age group given is 6 weeks old, presents with recurrent bilious vomiting, visible peristalsis and mass in the abdomen. Okay, so I think the question here is like non-bilious vomiting because the ultrasound is somewhat towards non-bilious. So this most probably could be non-bilious vomiting, visible peristalsis and mass in the abdomen. Ultrasound was given and this was the ultrasound given. So what is that you see in the ultrasound? So you can see the pylorus in the ultrasound. So pylorus, which is very long. So where do you see a newborn or an infant who presents with recurrent non-bilious vomiting, visible peristalsis, along with the pylorus, which is very thick and long? The condition is nothing but IHPS. So the answer is IHPS, idiopathic hypertrophic pyloric stenosis. Yes, idiopathic hypertrophic pyloric stenosis. What about the other options? Duodenal atresia. Yes, duodenal atresia cannot be there because this ultrasound is not of duodenal atresia. And in case of duodenal atresia, you will be getting recurrent bilious vomiting and no abdominal distension. Okay, you will not have abdominal distension in duodenal atresia. Fine. Annular pancreas and malnutrition also, they are not going to present in the immediate newborn period or in the early infancy, and that too you're not going to have these kind of ultrasound features. So this is typical of congenital hypertrophic pyloric stenosis or IHPS. So most probably this could have been non-bilious and not bilious. Okay, so this was also a repeat topic. Multiple times we have discussed in our VSP as well. So recurrent non-bilious vomiting, you will have visible gastric peristalsis and you will have an olive-shaped mass in the epigastrium. Okay, so very important thing on IHPS is the metabolic abnormality, hypokalemia, hypochloremia, metabolic alkalosis with paradoxical aciduria. So what is the ultrasound finding? Two things we have to see in the ultrasound: length of the pylorus and thickness of the pylorus. Length will be more than or equal to 16 millimeter. Thickness will be more than or equal to 4 millimeter. And the treatment is Ramsted's pyloromyotomy. Okay. So moving on to the third question. So this was the third question. So they gave an image of a foreign body and the question was, what is the sign seen in the X-ray given below? Okay. So the options were double ring sign, double string sign, steeple sign, thumb sign. Okay, we'll go from last. Thumb sign. No, this is not thumb sign. You all know thumb sign is seen in a condition called as, yes, acute epiglottitis. Okay. So you're not going to see foreign body there. Steeple sign is seen in a condition called as ALTB, acute laryngotracheal bronchitis, that is croup. Double string sign, okay, it is seen in IHPS. In variant meal, you can see double string sign in IHPS. Double ring sign is what is seen here. Okay, can you see one ring, and then another ring. Double ring or double ring sign. This is seen in case of a foreign body, that is the button battery. So this is button battery. Where is the button battery? So as I've told you multiple times, when you see a flat object like an O in an anteroposterior view, the location is going to be in the esophagus, O for esophagus. So this is a button battery in the esophagus. So foreign body in airway. So when you have a homogeneous round object, it is a coin. But when you have a double ring sign or a double halo sign as shown here, it is a button battery. And on lateral view, you will see a step off sign in case of a button battery, which means it needs immediate removal. So the answer is double ring sign. Fourth question, another question which is multiple time repeat in previous exams as well, an important topic, triad of hydrocephalus, chorioretinitis, and intracranial calcification, which is a very direct one, and the answer everyone knows is going to be congenital toxoplasmosis. Okay, so this triad is seen in congenital toxoplasmosis. So this is the triad we see in congenital toxoplasmosis, where we have diffuse intracranial calcifications. Suppose they gave periventricular calcifications, then you will think of a condition called as congenital CMV. So drug of choice in pregnancy is going to be spiramycin. Moving on to the next question. Again, a repeat question, but asked in a different way. So the question was, a girl presents with primary amenorrhea and short stature. That was given in the question, and an image of karyotyping was given, and they have asked what is the diagnosis. So if you look at the question, we have clues: primary amenorrhea, short stature, female. Okay, 3 important clues are there. And when you look at the karyotype, you can see that, yes, 1, 2, 3. So all your chromosomes are there. But look at the 6 chromosomes. You see only one X. You don't have another X or Y. So as we say it is a girl, you have to have another X, but we have only one X. So what is the karyotype here? XO. So a girl with XO karyotype, primary amenorrhea, short stature, everyone knows the answer is going to be Turner syndrome. So the answer for this question is Turner syndrome. So the classical features of Turner syndrome, it is a sex chromosome defect, 45XO, webbed neck, shield-like chest, streak ovaries, primary amenorrhea, and bicuspid aortic valve is common, and coarctation. So renal shows horseshoe kidney. Sensorineural hearing loss is also a feature. Important thing, they also present with short stature. Moving on to the next question, a pedigree chart was given, and they have asked to identify which disease follows this pattern of inheritance. So looking at the pedigree, this was the pedigree given. So whenever you see dotted line, circles or dots in between, it means it is a carrier. So you can see carrier state in this. So when you have a carrier state, it is going to be recessive. So you want to see whether it's going to be autosomal recessive or X-linked recessive. That's all. So you see, look at all the carriers. All the carriers are females, right? Look at the persons affected. Persons affected are males. So what are the things we see here? Females are carriers. Yes, males are affected. Now we are going to see about the transmission. When a female is a carrier, the male is affected. When the male is affected, it is not going to the next generation. You can see only carriers. So females are carriers, males are affected, and males do not transmit the disease. So what is this kind of inheritance called as? X-linked recessive. This is X-linked recessive. So now among the options, we will see which is X-linked recessive. Wilson? No, Wilson disease is autosomal recessive. Yes. Prader-Willi is something to do with chromosome 15 deletion, which comes under a group of diseases called as genomic imprinting. Okay? Genomic imprinting. So that is also ruled out. Achondroplasia is autosomal dominant in inheritance. So by ruling out everything, we are left with Wiskott-Aldrich syndrome. Yes, Wiskott-Aldrich syndrome is X-linked recessive. Okay. What is this Wiskott-Aldrich syndrome? So Wiskott-Aldrich syndrome is a triad of thrombocytopenia, eczema, and recurrent infections. It is an X-linked recessive disorder and also has microthrombocytopenia. You will have small platelets. So this is the triad of Wiskott-Aldrich syndrome. Is going to the next question, seventh question, another repeat topic. So a child presents with findings as shown in the image below. This was the image given. So what is seen in the image? You see a ring in the cornea, which is due to copper deposition. So what is the disease? Yes, it is Wilson disease. So Wilson disease is the diagnosis, but that is not asked in the question. They have asked the best investigation. So whenever Wilson comes, the best investigation, the investigation of choice, as we have discussed in VSV also. Yes, what is it? Investigation of choice. Hepatic copper content. Yes. So liver biopsy is the investigation of choice. So that becomes the answer. Hepatic copper is the investigation of choice. What about the other things? Urine copper, it will be increases, but it cannot be taken as the investigation of choice. Serum ceruloplasmin will be reduced in case of Wilson, and that is a screening test. They didn't ask about screening, they asked about best. So you go for hepatic copper. So MRI brain is not used for diagnosis. Whenever it is for diagnosis, liver biopsy or hepatic copper is the answer. Yes. Another question. So thiamine deficiency is seen in persons consuming dash. Students told me they gave a plate of food items and then they gave ABCD and they asked to choose that which food item can cause thiamine deficiency. Yes, thiamine deficiency is exclusively seen in patients taking polished rice. Okay. So those who are taking polished rice, they will present with thiamine deficiency. So rice, if it was there in the option, that becomes the answer. Okay, so polished rice consumption. Next question, multiple time repeats. You don't see a paper without this question or without this image in the paper. What is it? Crumpled tissue paper appearance. See, crumpled tissue paper appearance. It is seen in the deficiency of dash. So where do you see crumpled tissue paper appearance? Yes, it is seen in bone marrow histopathology. In bone marrow, in case of Gaucher's disease, you see this crumpled tissue paper appearance. So Gaucher's disease is due to deficiency of what? Is it alpha glucosidase, glucocerebrosidase, or acid lipase? No, alpha glucosidase is actually what? Form P. Yes, acid lipase is Ullmann disease. So what is the answer? Yes, glucocerebrosidase or beta glucosidase. Both are seen. Okay, so Gaucher beta glucosidase is the answer for that question. So Gaucher, very important topic for any entrance exam, characterized by red spot, beta glucosidase deficiency, hepatomegaly with developmental delay. So in the bone marrow, you see crumpled tissue paper, and you also have an Erlenmeyer flask deformity. Okay, so you have enzyme replacement therapy as well for Gaucher disease. So this is about Gaucher. Yes. Another image-based question. This question we have discussed even in our clinical refresher course. So this is a question which is a previous NEET-PG repeat also. So what is this? So you see some protrusion of mucosa which is present slightly in the pelvic region. So is it omphalocele, gastroschisis, or bladder extrophy? Yes. What is it? It is nothing but bladder extrophy. Here, this region, pelvic region, this is bladder extrophy. What about omphalocele and gastroschisis? See, omphalocele, you see the swelling or the protrusion will be present near the umbilicus. Okay, and it will be covered by a sac. Yes. Gastroschisis will not be covered by a sac. You will see the intestinal contents, okay, the abdominal contents outside. It is not covered by a sac and it is para-umbilical. Okay, but these two swellings, these two protrusions, they will not be present over the pelvis. They will be along with your umbilicus. But this is somewhere in the pelvis. This is nothing but the ectopia vesicae or bladder extrophy. Yes, question number 11. Two questions from this topic, very important topic. Yes, a child presents with diarrhea, chronic diarrhea, skin rash. Biopsy shows villus atrophy and crypt hyperplasia. Two important findings. Which among the following will be elevated in this condition, and a set of options were given. So with this, we know what the diagnosis is. Child with chronic diarrhea, biopsy, villus atrophy, crypt hyperplasia. The diagnosis is nothing but celiac. Yes. So what is this skin rash? What is the skin rash? We also discussed in BSV. Yes. What is the skin finding you see in celiac disease? It is called as dermatitis herpetiformis. Okay. So this is what they have given in the question, dermatitis herpetiformis. So what is that which is elevated in celiac disease? Yes. Anti-TTG. What is anti-TTG? Anti-tissue transglutaminase antibody will be elevated in cases of celiac disease. So that is the answer for the first question. You have another question from celiac disease. So the question goes like this. A child presents with chronic diarrhea, failure to thrive, and parasitic infections were ruled out. So patient was advised to restrict gluten. So this direct statement was given. Gluten should be restricted in diet. Okay. So what is the likely diagnosis? So the other name of celiac disease is gluten insensitivity. We all know. So the answer is actually celiac. So two questions from celiac disease. It is not Whipple's. Whipple's is an infection. Pancreatitis, okay, they are not going to present with this kind of features for chronic diarrhea and all. And you're not going to ask them to restrict gluten in their diet. So this word directly points to the answer celiac disease. So what is this celiac disease? It is because of gluten sensitivity. They are hypersensitive to gluten. So we have to avoid certain substances. What are they? Bro, that is the barley, rye, oats, and wheat. So they will have anti-TTGA elevated. Also, IgA levels will be reduced. A classical biopsy feature of villus atrophy and crypt hyperplasia will be seen. What is the treatment? Avoid gluten. That's all. So two questions from celiac disease. Okay, next question. A 16 years old male child claims himself to be 18 years. Okay. So which X-ray would you advise to estimate age? So to know the bone age, you have to take X-rays. So the child is 16, but he says he's 18 years. So whenever you want to know the bone age of a particular child, what we usually do is the wrist X-ray. So based on the carpal bones, we can assign the age of the child. So we already discussed this during discussion of bone age aspect. So here we have options with knee, shoulder, wrist, knee, head, shoulder. So the option which has wrist is option B. So we will go with option B. So the answer is wrist and knee is the answer for this question. Yes. Another question is, a patient presents with follicular hyperkeratosis over the forearm, and they say there is deficiency of vitamin A. So these two things, there's a skin finding and vitamin A is deficient. What is the diagnosis? So we have discussed vitamin A not only has problem with the eye, it also has problem with the skin and mucosa, epithelium. So when there is vitamin A deficiency, you have a condition called as phrinoderma. This phrinoderma presents as follicular hyperkeratosis over the forearm and elbows. The answer is phrinoderma. 15th question, another question, repeat question. A child presenting with hyperuricemia and self-mutilating behavior. What is the diagnosis? Yes, the diagnosis is nothing but a syndrome called as Lesch-Nyhan syndrome. Okay, it is Lesch-Nyhan syndrome. What is this Lesch-Nyhan syndrome? This is due to deficiency of hypoxanthine guanine phosphoribosyl transferase. Okay, this is the enzyme, very, very important. Hypoxanthine guanine phosphoribosyl transferase. Okay. So what happens due to this deficiency? These children, they present with increased uric acid levels. So they can present with features suggestive of acute gouty arthritis, and they will have these kind of self-mutilating behavior like biting nails, hand biting, head banging and all. Okay. So the answer is actually Lesch-Nyhan syndrome, which is due to HDPRT deficiency. Okay. So next question. So this was the history given. A child presents with recurrent lower respiratory tract infection. An X-ray of the child was given, and the question was, what is the diagnosis? So when you look at the X-ray, so you could see multiple air fluid levels, multiple cysts. Can you see? And what is that you see here? there is a mediastinal shift. Okay, so there is a mediastinal shift, multiple air fluid levels in an infant. So what is the diagnosis? So the options were CPAM, consolidation, nematocele. So this is not nematocele. Nematocele will be like a single cystic cavity. It is not going to have multiple air fluid levels, mediastinal shift and all. Okay, and they are going to have infection, not multiple episodes and all. So nematocele is ruled out. It is not consolidation because we know consolidation is a homogeneous opacity. You're not going to have mediastinal shift and you're going to have an homogeneous opacity. So consolidation is also ruled out. The answer is CPAM. What is CPAM? CPAM is congenital pulmonary airway malformations. Congenital pulmonary airway malformations. Previously, it was called as CCAM, congenital cystinomatoid malformations. So these are multiple cysts which is present in the thoracic cavity, which can cause mediastinal shift. They can present as respiratory distress in the infancy and newborn period. They can also lead to recurrent respiratory infections, and when they rupture, they can lead to pneumothorax. So these are the problems with CPAM. So this is the classical X-ray that was given. The answer is actually CPAM. Yes. Another question, we have already discussed this in our class, and this is also a repeat question from INI-CET. A child presents with deformity as shown in the image below. Lab values was given. So when you see the deformity, this was the deformity. What is this deformity called as? This deformity is called as windswept deformity. This is called as windswept deformity. Okay, so like this, one varum and one valgum deformity. This is called as windswept deformity. So this windswept deformity, where do you see? When a child comes with windswept deformity or any deformity of the bones, the first diagnosis is going to be rickets, right? It is going to be rickets. And they have given you a set of lab values. What are the set of lab values they are given? So low phosphorus. Phosphorus is reduced. PTH is normal. Calcium is normal. Okay, so coming to the options, VDDR type 1, VDDR type 2, X-linked hypophosphatemic rickets, nutritional rickets. These are given as the options. So come to nutritional rickets. So can this be nutritional rickets? If it is nutritional rickets, what happens to calcium? Less. What happens to PTH? It is going to be high. It will not be normal. So it is not nutritional rickets. Suppose. Come to VDDR type 1 and type 2. So VDDR type 1 and type 2 is nothing but vitamin D dependent rickets. So they are also going to have the same features like vitamin D deficiency only. If you give vitamin D, they will respond. If you stop vitamin D, they will not respond. And they will be needing long doses and high doses of vitamin D. So these lab values will also be similar to nutritional rickets. So these two are also ruled out. But per se, just look at these. Phosphorus is low, PTH is normal, calcium is normal. This is X-linked hypophosphatemic rickets. Okay, so the answer is actually X-linked hypophosphatemic rickets. So this approach we have discussed in the class. So whenever they give you a case of rickets, which is refractory, you think it is not nutritional, the first thing we are going to see is the phosphorus. So if the phosphorus is low, next thing you're going to see is the pH. So here in our case, phosphorus is low. So I'm going to look at the pH. pH normal acidosis, we don't have any record of the pH and all. So we think it is normal. If it is acidosis, they would have given us. So it is normal. So the next thing we are going to see is the PTH and calcium values. Now our PTH and calcium values are what? They are normal. When PTH and calcium are normal, phosphorus is low. What is going to be my diagnosis? Yes, hypophosphatemic rickets, X-linked. Okay, it is an X-linked dominant condition. So the answer is X-linked hypophosphatemic rickets. Yes. Next question, a pretty simple question actually. A midwife was conducting a normal vaginal delivery. Which among the following should not be done immediately after delivery, which you should not do? Skin to skin contact. You all know skin to skin contact is very important. So yes, you can do skin to skin contact. Immediate breastfeeding. Yes, WHO says immediately after birth, you have to breastfeed. So that is also acceptable. Drying the baby during newborn resuscitation. The routine steps include warm the baby, dry the baby, and cover the baby, right? So drying the baby is also acceptable. What about bathing the baby? Do we bath the baby? No. you should never bath the baby at least in the first 24 hours. Okay. Preferably, you will bath the baby only after the cord falls. Before that, you will just wipe the baby with a clean cloth. But if you want to bath the baby, you will not do it in the first 24 hours because of risk of hypothermia. Okay. So bathing the baby is not acceptable, and that is the answer for this question. Yes. Another question. A direct question asked from our clinical refresher course. So those who have attended this, you would have known this. Okay. So they have given you the growth curves and they have asked you what is the pattern of growth of different tissues. See, this was the question I took from our clinical refresher course. So the same question was asked. So the first curve. So first curve, you see, up to 2 years, there is a drastic rise and then there is a plateau. So initial 2 years, when the growth is more and then it becomes a plateau, it is what? Yes, brain. Second curve, you see a sigmoid, yes, shaped curve, yes, sigmoid shaped curve. And you see there is a peak in the immediate postnatal period, and then there is a plateau, and there is a peak again at puberty. So this kind of S-shaped sigmoid curve is seen in somatic tissue. Yes. The next one. Here you see there is a peak during the middle childhood. After puberty, this falls. What is this? This is lymphoid tissue. Yes. The last one. It is dormant till puberty. After puberty, what happens? There is a rapid increase. So after puberty, which increases? Your gonads. Yes, gonads. Fine. So these are different patterns of growth. So we already discussed brain, gonad, somatic, and lymphoid. Okay. Next. I heard there was another question from growth chart where they gave the growth chart and then they asked which shows growth retardation. So this was similar to this, and people told me that was not quite legible where the curves and all. Okay, we'll try to see. So 3 curves were given. So when you see the A curve, yes, it is well above the normal. Okay, so it is within the normal limits. It is well above the 0 standard deviation. So that is normal, A curve. Look at B curve. Look, B curve is also starting low, but it is following a pattern and it is between 0 to -2 standard deviation. 0 to -2 standard deviation is also normal. So anything above +2 standard deviation and anything below -2 standard deviation is abnormal. Within these two are going to be, within the red lines are normal, away from the red lines or below and above the red lines are abnormal. So B is also normal. But look at C. It was normal up till a period of time and then there is a dip in the growth. Okay. So this changing of percentiles is what is called as retardation or failure to thrive. So if such a graph is given, C would be the answer for that question. Okay. So these are some of the questions which I got from the morning shift. So now let's move on to the evening sessions. So evening sessions, we didn't have any question from growth or development. Most of the questions were integrated kind of questions and from systemic pediatrics in evening session. Yes. A 16 years old male child presented with fever, dyspnea, breathlessness, right ankle pain, pedal edema, pansystolic murmur with heat. CRP is elevated, ESR is elevated, rheumatoid factor is negative. What is the diagnosis? So we have multiple issues going on here. So there's fever, there is breathlessness, there is a murmur, they're given inflammatory markers are elevated, and rheumatoid factor is negative. What is the answer? JRA, acute rheumatic fever, infective endocarditis. Can this be juvenile rheumatoid arthritis? So just because RF is negative, you cannot omit juvenile rheumatoid arthritis because there is an entity in juvenile rheumatoid arthritis where the rheumatoid factor will be negative. Okay, a seronegative rheumatoid arthritis is also a possibility, but these features have to be there for a period of at least 6 weeks for you to diagnose JRA. Okay, and then looking at these kind of pansystolic murmur and all, it is not a classical feature of JRA. Okay, so JRA, it is not the apt answer as of now. We'll move on to infective endocarditis. Can it present with these features be in infective endocarditis? Yes. Fever, dyspnea is possible, pedal edema, murmur is also possible. But what is the reason for infective endocarditis? Do we have an existing heart disease? Why they have given about this ankle pain and all? Okay, so infective endocarditis cannot also be apt answer. But what about acute rheumatic fever? So does it follow our Jones criteria? Yes. So you see murmur with heave, so it is carditis. CRP elevated, ESR elevated. So this is the minor criteria along with ankle pain and swelling, which is arthritis. So you see one major, two minor criteria being satisfied. So this is actually a acute rheumatic fever, which we have already discussed. So the major criteria: carditis, arthritis, chorea, erythema marginatum, and subcutaneous nodules. Minor criteria being monoarthralgia or polyarthralgia, depending upon the high risk or low risk category. Fever, ESR elevated, prolonged PR interval, CRP elevated. So this satisfies Jones criteria, and then the answer is going to be acute rheumatic fever. Yes, next question. So this was the scenario given: a floppy infant, an infant with hypotonia, and then X-ray was given. So the X-ray was like there was a huge heart. So many people got confused with PGA, TAPVC, and all. So the classical clue they gave here is a floppy infant. So hypotonia with cardiomegaly, cardiomyopathy, cardiomegaly. What is the diagnosis? Yes, we have discussed this already. Hypotonia with cardiomegaly. The diagnosis is going to be an inborn error of metabolism, which is due to alpha glucosidase deficiency, which is Pompey's disease. Okay. What about the other options? Von Jerky. Von Jerky is type 1 GSD, which presents with hepatomegaly, hyperuricemia, renomegaly, doll-like tissues. Okay, so that is different. Okay, so sarcoidosis, not a possibility. Yes, you can have cardiac features which rare, but hypotonia is not a possibility. Smith-Magenis syndrome, it is because of a deletion of chromosome 70. There also you're not going to have floppy infant and all. Okay, so the direct answer here is going to be Pompey's disease. Yes, which is due to acid maltase or alpha glucosidase deficiency. An infant with hypotonia and cardiomyopathy, please think of Pompey's disease. Third question. So this is a slightly difficult question because a child diagnosed with phenylketonuria. Fine. This on low phenylalanine diet. Yes, any case of phenylketonuria, you're going to cut phenylalanine in the diet. But phenylalanine activity is increased despite you restricting the phenylalanine, the level is increased. Then what is the enzyme which is deficient? This was asked and 4 enzymes were given. Okay. So phenylalanine hydroxylase was in the option. Can it be phenylalanine hydroxylase? We all know in classic phenylketonuria, the deficiency is phenylalanine hydroxylase. But in classic phenylketonuria, as you see here, phenylalanine is converted to tyrosine, right? Here we have an enzyme called as phenylalanine hydroxylase. If this enzyme is deficient, what is going to happen? Phenylalanine is going to get increased. This is the one which is causing all the problems in PKU. All your intellectual disability and all is due to this increased phenylalanine. If this phenylalanine is restricted in the diet because it cannot be produced in our body, it is an essential amino acid. So when you restrict it in the diet, what is going to happen? The symptoms are going to improve. But if it is due to phenylalanine hydroxylase, it will respond to low phenylalanine diet. But there are also other enzymes which can cause increase in phenylalanine levels. So what is that deficiency? This deficiency. What is it? Dihydrobiopteridine reductase. So dihydropteridine reductase is an enzyme which reduces dihydrobiopterin to tetrahydrobiopterin. So this is the enzyme. So if this enzyme is deficient, you will not have tetrahydrobiopterin. This tetrahydrobiopterin is a cofactor for our phenylalanine hydroxylase. So in this deficiency, even if you restrict phenylalanine, because of absence of tetrahydrobiopterin, what is going to happen? Phenylalanine will not be converted and the levels of phenylalanine are going to increase. That is what was asked in our question. So this is not a case of classical phenylketonuria. This is a case of hyperphenylalaninemia, but not because of PKU. Okay. So what is it? It is because of dihydrobiopterin reductase deficiency. Okay. Yes. Fourth question. Repeat, multiple time repeated question. A neonate presents with vomiting, hepatomegaly, jaundice. Features as shown in the image below. What is the enzyme deficient? What is the feature? This is leukorrhea. So leukorrhea, where do you see? Yes, it is nothing but congenital cataract. So a neonate with vomiting, hepatomegaly, jaundice, cataract, you will think of one important condition called as galactosemia. Okay, fine. So what is the enzyme deficiency that causes galactosemia? Aldol reductase? No, it is not aldol reductase. Aldol reductase is the one which is responsible for cataract. Okay. So what happens? The galactitol is produced because of aldol reductase. So it is not a deficiency of aldol reductase. Glucose phosphatase? No. Glucose phosphatase causes 1-GFD, type 1 GSD. Okay. So galactose 1-phosphate uridyl transferase and galactokinase. So both the enzymes can cause galactosemia. How to differentiate whether it is the first one or the second one? See, in galactokinase deficiency, the only finding will be cataract. You will not have other features like hepatomegaly, vomiting, jaundice and all. The child will be absolutely normal. Only cataract will be there. But here in our question, they have given all this. So it is not galactokinase, and the answer is galactose 1-phosphate uridyl transferase deficiency, the GALT, which is deficient in galactosemia. Okay, so galactosemia. So this is what I was telling about. Galactose is converted to galactose 1-phosphate. We need galactokinase. Galactose 1-phosphate is converted to glucose 1-phosphate. We need GALT. When GALT is not there, this level increases and causes all the problems in galactosemia. The galactose, which is excess, converts to galactitol by aldose reductase, and this galactitol is the reason for cataract. So aldose reductase is the reason for cataract. Okay, and the deficiency of GALT is the reason for classical galactosemia. Fine. Fifth question. Some of them recall this question, and I'm not sure whether the exact question was there. A child with lytic skull lesions and skin rashes. What is the diagnosis? So when it is lytic skull lesions, skin rashes, I can think of only one thing, which is called as Langerhans cell histiocytosis. Langerhans cell histiocytosis. So child with lytic skin lesions and skin rash, Langerhans cell histiocytosis is the answer for that. A neonate presents with respiratory distress. On examination, bowel sounds are heard in the thoracic cavity with mediastinal shift. Okay, so a neonate presents with respiratory distress. On examination, typical feature, what is it? Bowel sounds. Where it is here? In the thoracic cavity. And there is a mediastinal shift. So with this, you know, the diagnosis is nothing but congenital diaphragmatic hernia. So in case of congenital diaphragmatic hernia, which is the most common site? That was the question asked. Okay. So what was the most common site? Yes, we have discussed already. What is it? Posterolateral Bogdelic hernia on the left side is most common. Okay. So what is the answer? Posterolateral. What is it called as? Bogdelic. And particularly on the left side is the most common cause of congenital diaphragmatic hernia and most common site. Okay. So the seventh question, there was another question in the evening session based on foreign body. So which among the following is true regarding this image? So this was given and there is a homogeneous foreign body, which is preferably a cone. So the options that was given was right main bronchus is mostly affected, cricopharynx is most common site, mediastinal infection is seen. So if you see here, it is not mediastinal infection. This is not mediastinal infection. This is a foreign body. Right main bronchus affected. No, you can see here the foreign body is a flat object which is present in the esophagus. We have already discussed. So this is not in the right main bronchus. So that is also ruled out. So cricopharynx is the most common site. Yes, in the esophagus, the most common site of obstruction is going to be cricopharynx. So the answer to this question is option A. Moving on to the next question. So this was a question on a 2-year-old child whose vitals are stable, who presented with supraventricular tachycardia. This was given. And what is the next step? Cardioversion, adenosine, 2 doses of adenosine is given. So the first thing whenever a child presents with supraventricular tachycardia is that we have to see whether the child is stable or unstable. How is the hemodynamic status? Stable or unstable. So if the child is stable, we will go to vagal maneuvers. and we will give adenosine. Okay, if the child is unstable, we will go with cardioversion, DC cardioversion. Okay, synchronized DT cardioversion. But here they say the child is stable. Okay, so when the vitals are stable, we are going for vagal maneuvers and adenosine. Vagal maneuver is not there in the option. So we are going into adenosine. What about the adenosine? They have given 2 doses of adenosine. The initial dose you give in adenosine is 0.1 milligram per kg. Adenosine has to be given with a rapid flush of saline, followed by a rapid flush of saline, because the action of adenosine is very less duration, and then you have to give it with the rapid flush of saline. So the initial dose is 0.1 milligram per kg. If the tachycardia does not respond to 0.1, then you increase to 0.2. Okay. So the answer here would be option C, 0.1 milligram per kg. So this is the ECG of SVT we discussed in class also. So you can see narrow complex tachycardia and there is no P wave. So any narrow complex tachycardia with the absence of P wave, it is going to be SVT. And when a patient is stable, go for adenosine. Unstable, go for DC cardioversion. 9th question. So this was a question with a child who was brought with a membrane over the tonsil and fever. So the diagnosis here is somewhat like diphtheria. Okay, the question was not about the patient, it is about a sibling. A sibling is fully immunized for age. What is true regarding prophylaxis to sibling? Okay, so they have asked what to do for the sibling. So the options given were pentavalent vaccine, you have to restart the schedule, DPT booster dose, penicillin prophylaxis, need not give any medications. Okay, see, when there is a contact of diphtheria, okay, so when you have a sibling or a contact of diphtheria, you're going to give prophylaxis and you're going to give booster doses. And you're going to give diphtheria toxoid. Okay, what prophylaxis? Erythromycin or penicillin? Okay, diphtheria toxoid. If the child is not immunized, you're going to give the full dose of vaccination. When a child is completely immunized, you're just going to give the booster dose. So the correct answer would be erythromycin or penicillin prophylaxis along with booster dose of toxoid. But as far as I got the recalls, these two were given as separate options. So which one to select? Pentavalent vaccines restart schedule is not the answer because here the child is already vaccinated. Need not give any medication. No, you have to give prophylaxis. Is it booster dose or penicillin prophylaxis? If you look at these two, I would say the better option here is booster dose, because booster dose is very important, the toxoid. Okay, and penicillin prophylaxis, if both of them were in the same option, that becomes the actual correct answer. Okay, so quite controversial, both are possible, but DPT booster dose is a better option compared to the other one. Yes, another question. So they've given an image of ILR, ice-lined refrigerator, and they've asked which can be kept in the lowermost compartment of this equipment. And this we have already discussed in class. So what are the options given? OPV, DPT, pentavalent, hepatitis B. Okay, I told you in class, anything which has T in it, do not freeze it, right? T in it, don't freeze. So DPT has T, pentavalent has T. Yes, hepatitis also has T. So you all know the answer is OPV. Okay, so look here. So this is the arrangement of vaccines in a ILR. You see OPV in the lowermost compartment, and measles, BCG, rota, all the live ones are in the lower compartment. But the ones with T, DPT, penta, hepatitis and all, they should not be freezed. They will be kept in the upper compartment. So the answer is OPV. Is another question which is also a repeat. So a child presents with hemoglobin 7.8. So there is going to be anemia. MCV, MCHC are low. Serum iron is reduced. TIBC, total iron binding capacity, is increased. So what is the diagnosis? Yes, what is it? Serum iron low, TIBC increased, transferrin high, transferrin saturation low. The direct answer here is iron deficiency anemia. Simple question and repeat question. Yes. 12th question. So here they gave a scenario and they asked what is the diagnosis. The scenario has hypokalemia. Bicarbonate is less than 15 milliequivalent per liter. So what is there? There is acidosis. So there is acidosis. and urine pH is increased. Urine pH, normal urine pH is somewhere around 5.5. Here it is 9, so urine pH is increased. Okay. So what is the likely diagnosis? We'll go from below. Is it Bartter syndrome? It cannot be Bartter syndrome because in Bartter syndrome, you will have hypokalemia with alkalosis, not acidosis. So Bartter is ruled out. Type 4 RTA? No. Type 4 RTA, what is the characteristic feature? Hyperkalemia is a characteristic feature of type 4 RTA. So that is also ruled out because here we have hypokalemia. Okay, fine. Between type 1 and type 2 RTA, what is the answer? So look at type 1 RTA, type 2 RTA. So type 1 RTA, we all know it is because of defect in the distal H plus secretion. Yes, type 2 RTA, it is because of the proximal bicarb reabsorption. Okay, reabsorption. So here, in case of type 1 RTA, what happens to the urine pH? Urine pH, distal H plus secretion is defective, H plus is not secreted, urine pH is increased. In type 2 RTA, urine pH will be reduced, less than 5.5. Okay, so here in our question, they have given urine pH is more, so it is not type 2 RTA and it is type 1 RTA. So the answer is type 1 RTA. Okay, fine. Another question. So a neonate did not pass meconium even after 48 hours of birth. What is the diagnosis? Yes, when there is delayed passage of meconium, one thing you will think in the newborn period is going to be your Hirschsprung disease. So Hirschsprung disease is the answer, but the question is not on what is the diagnosis. It is on the structures absent in this disease are seen in which of the following layers? Which of the following layers? So we know in Hirschsprung disease, the ganglions are absent. It is aganglionic. So what are the two layers? It is the submucosal layer and the muscular layer which is affected. What are the two plexus which is affected? The Auerbach's plexus and the myenteric plexus. So here submucosal, mucosal, muscular layer are affected. Okay, Auerbach's plexus and myenteric plexus are affected. They will present with delayed passage of meconium in the neonatal period, or later in life they can present with chronic constipation. Okay, so 14th question. A child presents with recurrent urinary tract infection and features shown in the image below. So what are the clues? Recurrent UTI. And an image is shown below. What is there in the image? You see a VCUG image. What is VCUG? Voiding cystourethrogram, where you see a filling defect. Can you see here? So here you see a filling defect and the distension of the bladder. So what is causing this obstruction and a filling defect? With bilateral, recurrent urinary tract infection, it is nothing but posterior urethral valve. Posterior urethral valve. Okay. So what is the recommended treatment in case of posterior urethral valve? In case of posterior urethral valve, you have to go for surgery. So you will go for fulguration of the valves. That is the answer. The valves has to be destroyed, or else it can cause chronic infections and it can cause recurrent urinary tract infections, VUR and all. Okay. So it is fulguration of the valve is the answer. So this already discussed. Endoscopic fulguration of the valve is the treatment of choice. You will see a filling defect in the micturating cystourethrogram and the ultrasound will show a keyhole sign. Okay. Next. So there was another question on hemophilia on the inheritance, I think. So not sure of the options, but hemophilia, we all know it is X-linked recessive. So as we discussed in the morning session question, so all males are affected, females will be carriers. So this is going to be the better option. Okay, males affected and females carriers, because hemophilia is also X-linked recessive. So these are some of the questions which I was able to get from the evening session. So I hope you have done your exams well. So fingers crossed, we'll wait for the results and hoping the best for you all. Thank you so much.